Okay, so today we're going to look at a very important condition called peptic ulcer disease. Okay, my name is Dr. Standom Kandawire, current practitioner at Levi Mwanawasa Teaching Hospital. Okay, we're going to look at peptic ulcer disease because it's one of the most common conditions in our setting and one of the most mismanaged conditions. Okay, so what is a peptic ulcer? A peptic ulcer is simply a break in the continuity of the mucosa layer, okay, which can either happen in the stomach or in the duodenum. Okay, when the erosion happens in the stomach, we call it a gastric ulcer, and when the erosion happens in the duodenum, we call it a duodenal ulcer. Okay, in our setting, peptic ulcers are more common in the males than in the females. About 90% of these ulcers are caused by a fraudulent gram-negative bacteria called Helicobacter pylori. Okay. When talking about the pathophysiology of peptic ulcers, we look at two important factors such as the protective factors and the aggressive factors or the aggravating factors. Okay, what are the protective factors? The body has a way in which it protects itself from these aggressive factors. Okay, so the body protects its mucosa layer or the lining in the stomach or in the duodenal layer by producing mucus. Okay, there is also presence of bicarbonate. There is rapid epithelial regeneration. Okay, there's no more mucosa blood flow and no more prostaglandin secretion. Okay, now when there's an imbalance or when the body is exposed to these aggressive factors for quite a long time, it distorts all these protective factors. Okay, when the body is exposed to Helicobacter pylori, which is a gram-negative fraudulent bacteria, it erodes the layer of the stomach lining. Okay, we've got drugs such as non-steroidal inflammatory drugs like the diclofenac, the ibuprofen. These drugs, prolonged use of these drugs, cause erosion. Okay, we've got corticosteroids, we've got aspirin, we've got smoking. Okay, we've got prolonged intake of alcohol, which can also erode the layer of the mucosa lining. We've got psychological stress. Okay, we've got Zolonga-Ellison syndrome. All these are aggressive factors which were not controlled or cured or cut off or taken into consideration, can destroy all these protective factors, and eventually it can lead into a bad state of causing a perforation. Okay. So when talking about the pathophysiology of peptic ulcers, always bring about the protective factors and the aggressive factors. An imbalance between these two things, these two systems, causes erosion of the mucosa layer. Okay. As you can see in this diagram, the mucosa layer has been eroded due to the aggressive factors, the aggressive damage. There's necrotic debris. Okay, there is inflammation, there's granulation in tissue there is damaged. It eventually leads to fibrosis, which eventually goes into perforation. Okay, so we need to take into account all these factors. Now we are going to talk about the most causative agent of peptic ulcers, which is Helicobacter pylori. Now this gram-negative slow-growing spiral organism, it is acquired through the fecal-oral route. Okay, because it is acquired through the fecal-oral route, that means improper hygiene, the foods we're eating, poor handling of food and stuff can cause ingestion of this bacteria, which goes to settle in the mucosa layer and colonizes the gastric antrum. Okay, it goes specifically in the duodenal area there and in the gastric layer, and it causes metaplasia. Okay, it's a very stubborn organism. Okay, so when it goes into the gastric layer, it has got mechanisms by which it causes damage. What are some of the mechanisms or which Helicobacter pylori causes damage? The most common mechanism which we would like to keep in our minds is the production of urease. It produces urease, okay, urease which cleaves the urea to ammonia, okay, and carbon dioxide, creating a buffer against the hydrochloric acid there. Now, that's why when you are doing investigations, just to mention is that we do a urease test, because this organism which we find in this which comes with this condition, it produces what? Urease. So in the body there will be a high concentration of urease. So we need to do a urease test as well. Okay. The other thing that it does, it brings about production of cytokines. Okay, cytokines such as interleukin-6, which recruits the neutrophils. Okay. It also brings about enhancement of gastric acid secretion and impairment of the duodenal bicarbonate production. Okay. The other mechanism is it adheres to the surface epithelial cells and secretes phospholipase, okay, and platelet activating factors and protease enzymes. Okay. So all these mechanisms are vital to eroding the mucosa layer. Okay, if not treated early, this organism will keep multiplying and eventually will cause a perforation. Okay, the other thing that it does is produces production of a passive urease transporter that creates cell damage. Okay, the other thing that it does, it produces a cytotoxic associated protein. Okay, which is important in destroying the mucosa layer. Okay, so the most important thing I want you to remember here is the production of urease, which is which cleaves the ammonia and which cleaves the urea to ammonia and carbon dioxide. Okay, so this is how the organism looks like. It's a gram-negative flagellant bacteria. It's a slow growing bacteria. Okay, so the mechanism is what we just talked about. Okay, so it produces that urease. Urease breaks down the urea to ammonia and carbon dioxide. Okay, and further on, it also breaks down the glycoprotein in the mucosa layer there. Okay, so these are some of the things we should remember when you're dealing with Helicobacter pylori. It's a very stubborn organism, and it has got multiple factors of which it can cause mucosa ulceration. Okay, so it can cause inflammation of the gastric layer. It can cause ulcers. Ulcers can occur at sites of chronic inflammation. Okay, it damages the mucosa layer. Okay, so the pathophysiology of this condition, apart from the protective and aggressive factors, you can just think of all these aggressive factors. Okay, all these aggressive factors such as the alcohol, the non-steroidal inflammatory drugs, smoking. Okay, the Helicobacter pylori. Okay. Or the psychological stress, all these things, okay, they cause oxidative damage to the DNA. Okay, when they cause oxidative damage to the DNA, oxidative damage to the proteins, what happens? There's a cellular response which happens. Okay, the cellular response which happens is that there's altered gene regulation. Okay, altered gene regulation, and there's loss of DNA repair activity due to the continuous progression of these aggressive factors. Okay, the DNA is undergoing oxidative damage, so there's loss of repair of DNA activity. So what happens in the cellular response? There is altered signal transduction. Okay, there's altered signal transduction. There's mutation which takes place there. Okay, there's altered cell growth. Okay, and differentiation, and it leads to cell death now. okay, apoptosis, okay. When all these things happen, when there's oxidative damage to the DNA, okay, what happens? The mucosal layer is damaged. There's epithelial injury there, okay. There's endothelial injury. There's inflammation, okay. The disease now causes ulceration. It can cause fibrosis. It can cause ischemia. Finally, it will cause a perforation. So I want you to remember the pathophysiology to say all these factors, the aggressive factors, they cause oxidative stress. Okay, when they cause oxidative stress, they alter the DNA repair or DNA gene regulation there in the cellular response. Okay, so there's altered signal transduction there. Okay, there's altered cell growth and differentiation. The cells won't grow as they are supposed to grow. There's delayed epithelial regeneration. Okay, so when all these factors are happening as cellular response, the mucosal layer now undergoes epithelial injury, endothelial injury, inflammation, eventually leading to an ulceration. Okay, so we should those things should come about when you're talking about the pathophysiology. Etiological factors, we've talked about them. We've talked about the most common one. Always remember is Helicobacter pylori. We've got NSAIDs. We've got smoking. We've got hyperacid secretion. We've got psychological stress. We've got a family history. Some articles say that people with a blood group type O have got a higher chance of developing peptic ulcer disease. Okay, so we've talked about the etiological factors most of the time. Okay, we won't waste much time. Okay, always remember that Helicobacter pylori is a gram-negative flagellant organism which produces urease, which breaks down the urea to ammonia and carbon dioxide, which goes there and causes oxidative DNA damage. Okay, it goes and colonizes into the gastric antrum, okay, and also into the duodenal antrum there, into the duodenal layer. Okay, so when this organism, when it produces urea, or when it produces the ammonia and carbon dioxide, the ammonia from the urease activity creates an alkaline environment, which has a feedback effect for increased gastric production. So the ammonia increases the alkalinic environment, because in the stomach it has to be an acidic environment, but this bacteria starts creating its own terms. What do you mean by its own terms? It creates an alkaline environment. Okay, it creates an alkaline environment which has a negative feedback, making the body produce more increased gastrin production, okay, which eventually causes erosion of the mucosal layer. Okay, Helicobacter pylori has got it has got an induced inflammatory reaction with cellular infiltration. Okay, so it causes epithelial damage. Okay, so those are some of the things which we need to put in our minds. The NSAIDs, there's inhibition of mucosal prostaglandin synthesis by suppressing of COX-1 activity. Okay, so when that happens, the NSAIDs decrease the production of gastric mucus, which normally repels the acid. So there's reduced production of gastric mucus in the stomach, leading to prolonged damage to the mucosal layer. Okay, so those are some of the things we need to remember. Okay, alcohol causes increased acid production. Okay, it leaches out the glycolipid layer under the mucosa coat there. Alcohol, it erodes. Okay, smoking. How does smoking cause Helicobacter pylori? Smoking increases the gastric acid production as well. Okay, the gastric acid production. Okay, it also induces duodenal gastric reflux. Okay, so sometimes, how does the psychological stress cause mucosa layer erosion? Okay, when you worry a lot or you under too much stress, you increase your vagal stimulation from worry and anxiety. Okay, that stimulation causes production of gastric acid. There's increased parietal cell mass. Okay, this can be genetic. Okay, so these are some of the factors which we need to put into consideration. Okay, yeah, and ischemia reduces the mucosa barrier defense. Okay, so all these things, we've got some things like enterogastric bowel reflux. This occurs if the pyloric sphincter just below the stomach there is incompetent, okay, or following a surgical procedure such as a gastrojejunostomy. Okay, so the bowel acids and the pancreatic secretions there stimulate the gastrin to release, okay, with increased acid output. Okay, so there is an improper communication with the body, so the body tends to keep stimulating production of gastrin. Okay, too much acid also erodes the mucosa layer. Okay, so all these risk factors, okay, they make the aggressive factors. Okay, so what is the difference between a gastric ulcer and a duodenal ulcer? We say that in a gastric ulcer, it occurs in the stomach, and the duodenal ulcer occurs in the duodenal area there. Okay, so how do patients present? Okay, how do patients present? So in gastric perforation, they will present with pain when they are hungry, pain when they are hungry. Okay, they'll say, doctor, I'm feeling pain when I'm hungry. But in duodenal ulcer, they'll just say, even when I'm hungry, I'm okay. Okay, these people usually after even if they are hungry, they are still okay. But with the gastric, the pain is present when they are hungry. Okay, malignancy is common with the duodenal ulcer, and malignancy is not common with the gastric ulcer. Okay, there is weight loss with gastric ulcers. Okay, there is weight loss, but for this one, the duodenal ulcer, there is no weight loss because the appetite is not very much disturbed. They can still eat. Okay, so in a gastric ulcer, the injury is caused by alcohol, NSAIDs, drugs, and other things. Okay, so the pain in the gastric ulcer is most common in the left epigastric region, and in the duodenal ulcer is in the right epigastric region. Okay, hope we're together. Clinical manifestations of peptic ulcer. So patients come in with poor appetite. They will just say, I no longer eat the way I used to eat. Okay, because it usually they usually have pain when they eat something there. Okay, so even if they are not eating as they used to eat, there is nausea, there is blood stool there, there's an explained weight loss, there's vomiting, there's epigastric pain. Okay, the most common symptom is they will present with a burning sensation in the abdominal area, epigastric region. They will present with a heartburn in most cases. Okay. So a duodenal ulcer is most commonly in the younger ones, but gastric is more commonly in the older people, the middle-aged. But this literature now is debatable because we see these ulcers in all ages now. Okay, we just see them in all ages. So we just need to know that a duodenal ulcer is common in the young ones, but a gastric ulcer is common in the middle-aged or the older people. Okay, so a duodenal ulcer, as I mentioned earlier, is aggravated by hunger. Then a gastric ulcer, when they don't eat, they will present with pain. Okay, when they don't eat, they present with pain. All right, so these are some of the things you're supposed to put into consideration. Okay, yes. So a duodenal ulcer, a gastric ulcer, I'll say again, there's pain when they are hungry. So when they eat something, they are relieved from that pain. Okay, so these are just the presentations of which we have talked about in the previous slides. We've talked about in the previous slides. Sorry about that. Okay, all this we've talked about. Okay, the clinical features, we also talked about them. There's a burning sensation, There's pain when they do not eat, okay? They present with vomiting, nausea, okay? All these symptoms should come into your history taking when you're talking about ulcers. Yes, so now we move on quickly to the investigations. When you're talking about the investigations for peptic ulcer, you need to be very specific. You need to tell us about the invasive. You need to classify your investigations into non-invasive and invasive investigations. Okay, under non-invasive, you're going to tell us you're going to do H. pylori tests. Okay, H. pylori test. You're also going to do a urease test. Okay, under invasive, you can do an endoscopy. Under invasive, you can do an endoscopy. So you insert a camera. It's just like a camera a camera tube which goes into the stomach and shows us where the specific ulceration is. Okay, so you can do that. You can also do a CT scan. Okay, under the imaging, you can do a CT scan. Okay, but all these investigations should come out. You should classify them into non-invasive and invasive investigations. So we're just talking about the same thing. You can do an endoscopy. You can do an endoscopy. You can do an endoscopy. Okay, the endoscopy will show us where that lesion is. You can do H. pylori tests there. Okay, H. pylori test will stop the protein. Will show us the protein, stop the protein pump inhibitors 2 weeks before, so that this examination comes out, or this test comes out positive. You can also do a urea breath test. Okay, it's simple and it's rapid and it's useful for early follow-up. But false negative with this thing is it's possible. It's high. The test is sensitive, but sometimes it can give us a false positive if there's a recent treatment of this condition. Okay, we can also do a S2 antigen test. Okay, S2 antigen test. So we get the fecal matter there and we do S2 antigen test. Okay, we can also do barium studies. Okay, barium studies. You can do a barium meal for the stomach. Okay, which is sensitive of this investigation to detect ulcers. Okay, we can do a full blood count. Okay, full blood count to check if this patient has anemia, because they are exposed to high levels of malnutrition. They are not eating as they are supposed to eat, so their body is not getting the nutrients that they are supposed to get. So we can do those investigations. So amongst all these investigations, the only invasive one is the endoscopy one. The other ones, you classify them under what? Under non-invasive. The H. pylori test, the urease breath test, the two antigen, the barium studies, and the full blood count. Okay. Okay, you can also do under the endoscopy test. You can just specify to say I can do an esophageal gastroduodenoscopy. Okay, just to specify where you want the endoscopy procedure to be done. Okay. Okay, so all these procedures, we talked about the barium swallow, we talk about the urease breath test. Okay, used to detect H. pylori. Okay. Okay, this is just an example of an endoscopy. The camera is set there with a tube and it shows us the specific lesion. Differentials for peptic ulcer disease, we've got reflux esophagitis, we've got cholelithiasis, we've got pancreatitis, we've got gastric cancer. Most times patients with gastric cancer, they present like they have a peptic ulcer. Okay, so in this criteria, all patients above 50, you need to suspect them of having gastric cancer unless proven otherwise. Okay, we've got cancer of the transverse colon. Okay, we've got reflex esophagitis. Okay, so the presentations of reflex esophagitis can mimic the presentation of peptic ulcer disease. Okay, we go to the management. So when you're talking about management, you classify the management into medical management, or pharmacological management, and surgical management. Okay, or if you want to make things more interesting, you can classify them into non-pharmacological, pharmacological, and surgical. Non-pharmacological, you talk about lifestyle modifications. If they are drinking alcohol, you tell them to stop drinking alcohol or reduce. If they are smoking, you tell them to stop smoking. If they are on drugs like NSAIDs or corticosteroids, you tell them to cut off those drugs until they are properly healed of peptic ulcers. Okay, so that's another lifestyle modification. You improve their diet. They should reduce intake of these spicy foods, because those things can erode the mucosa layer. Okay, we talk about the triple therapy for medical treatment or pharmacological treatment. Triple therapy involves it just simply means 3 drugs. Okay, 1 protein pump inhibitor and 2 antibiotics. So we've got omeprazole as a protein pump inhibitor. Omeprazole, you give about 20 milligrams twice daily. We've got we can use clarithromycin. Clarithromycin we give 500 milligrams twice daily. Then the only antibiotic you can substitute in this thing, I'll repeat. The only antibiotic you can substitute is a third one. If you don't have metronidazole, you can give amoxicillin. Okay, so you don't change the 2 drugs, you don't change omeprazole and clarithromycin, but you can change the third one, the metronidazole, the anaerobe, the one which covers the anaerobes. Okay, so metronidazole is under the nitroimidazole types of antibiotics, so you can change it, okay, or give amoxicillin if it's not present there. Okay, we take all these drugs, the triple therapy, we take it for a duration of 14 days, 2 weeks, not less than 2 weeks. And if you're prescribing magnesium for someone with a peptic ulcer, you're doing the wrong thing. Okay, you always give them a triple therapy, because it's the best therapy for these patients, and it cures that stubborn gram-negative flagellant bacteria, the H. pylori. Then, if this triple therapy does not do well, which is rare in most cases in our setting, we can go to a quadruple therapy, which involves 4 drugs. Quadruple just means 4 drugs. We've got bismuth subsalicate, okay, or we've got omeprazole, we've got metronidazole, and tetracycline. Okay, so you give this therapy as well if the triple therapy does not do well. In most cases, it's rare a triple therapy does well, but if in cases where it does not do well, we can go for a quadruple therapy, which involves the bismuth bismuth subsalicate, and omeprazole, and metronidazole, and tetracycline. Okay, yes, so those are the medical managements of peptic ulcers. Okay, all right, so we've talked about lifestyle modification and all these things. Okay, we talked about lifestyle modification. You told them to stop smoking, limit alcohol intake, avoid spicy foods, avoid caffeine containing foods, get good rest and sleep, because you know that pharmacological stress can cause peptic ulcers. Okay, they should exercise, they should eat fruits, avoid NSAIDs. Okay, some people even say use olive oil just to stop the inflammation. Okay, but lifestyle modification is also a part of the treatment. Okay. Okay, so we move directly to the surgical treatment. Surgical treatment, we have got certain procedures which we do for perforated peptic ulcers. You only do surgical management if the peptic ulcer is perforated or the progression of the mucosal lining is going to perforate. So we do a subtotal gastrectomy. Okay. Which removes about one third or 2/3 of the stomach. The remainder is attached to the rest of the bowel. Okay, we call this procedure, we've got 2 types of subtotal gastrectomy. We've got the Bureth 1 and the Bureth 2. Okay, so this is an example of the Bureth 1. The distal portion of the stomach is removed. The remainder is anastomosed to the duodenum. Okay, This is how the Bureau 1 is done. Okay, you've got the Bureau 2. The lower portion of the stomach is removed, and the remainder is anastomosis to the duodenum. Okay, the duodenum. Okay. We also have a procedure which you can do. We've got a vagotomy. We can do a vagotomy. Types of vagotomy: we've got a truncal, we've got a selective, we've got a proximal parietal cell. Okay, it's also a surgical procedure. So vagotomy, you know that what happens in a vagotomy, you just cut the vagus nerve. Okay, it eliminates the acid secreting stimulus to the gastric cells and decreases the responsiveness of the parietal cells. Okay, so there won't be secretion of the gastric acid. Okay, it will eliminate the acid secreting stimulus and decreases the responsiveness of the parietal cells. Okay, we've got a pyroplasty. You can do a pyroplasty. You can widen the pylorus, the engine of the stomach there. Okay, widen the pylorus of the stomach. Okay, it's going to guarantee emptying even without vagus stimulation, vagus nerve stimulation. Okay, so these are the same procedures we're talking about. This is just the same as a gastroenterostomy. It allows regurgitation of the alkaline duodenum contents into the stomach. Okay, it creates a passage between the body of the stomach to the small intestines. Okay, so all these surgical procedures have got an effect. Okay, you have to cancel the patient after you do all these surgical procedures: the subtotal gastrectomy, okay, the pyroplasty, the vagotomy. Okay, but most of the time it's subtotal gastrotomy. You have to warn the patient, cancel the patient to say they will have a condition which you call dumpling syndrome. Okay, or dumping syndrome. Okay, dumping syndrome, the food, there will be rapid emptying of food and fluids from the stomach into the duodenum. Okay, so symptoms will present with weakness, faintness, there will be palpitations, there will be fullness, there will be discomfort, nausea, and diarrhea. Okay, so how do we counsel the patient with dumping syndrome? You advise them to eat slowly. Okay, if the food they eat, they are supposed to eat for 5 minutes. You tell them you have to eat that food for 15 minutes so that you allow proper digestion of that food. Okay, you avoid fluids during meals. Okay, you increase the fat. You eat in small and frequent meals. You don't eat everything at once. You eat small portions. Okay, yes. So this ends our discussion on peptic ulcers, but let's just talk about some of the complications of peptic ulcers is perforations. You can talk about anemias. Okay, you can talk about it can complicate into a malignancy. Okay, it can cause bleeding. Okay, so those are some of the complications of peptic ulcers. So thank you for listening to this session, and I hope you've gotten one or two things on peptic ulcer disease. Okay, stay blessed.